So the next scenario is that, so you have a 58-year-old patient, history of diabetes, hypertension, and medication. He presented to your emergency department in cardiac arrest. So, and after about 25 minutes of high quality CPR and three defibrillation attempts, you find for ventricular fibrillation, you finally attain ROSC. And post-ROSC, you do an ECG and it shows acceleration in the anterior limits. So what are the things that you should consider in such patients that would make you want to go for emergent PCI? So, and angiography after out of hospital cardiac arrest. So, who is going to benefit from those? So, what initially used to happen is was that it was generally recommended that every patient come presenting with hospital cardiac arrest should be taken for emergent angiography. But the concept in recent years has changed with the release of a few RCTs. The concept behind this has begun to change. So the important trials that you have to remember is the COAC trial and the Tomahawk trial. Both of these trials were done in Europe, and both of them are very similar. Both of them had some 500 something patient. Both of them were multi-center open label RCTs. The COAC trial, so coronary angiography after cardiac arrest without ST segment elevation. So when you have a STEMI, it is a class 1 recommendation as far as the age goes for emergent PCI. But what about patients without ST on the ECG? That becomes a gray area. So the COAT trial was trying to look at these patients, which was a multi-center RCT, and they looked at only shockable rhythms. And in patient presented with automatic cardiac arrest and time ROSC, and they did not have STEMI on the ECG. That 500 something patient, they were randomized to either in immediate angiography, that is within 2 hours, or delayed angiography until the patient is neurologically better. So the primary outcome in this study was 90-day mortality, and there was no difference between either of these approaches, and there was no differences in the proportion of good neurological outcome with either of these approaches. The second trial that was released little bit later, the COAT trial was released published around 2019. Tomahawk was released a little later than that. So it was similar, but this Tomahawk included shockable and non-shockable rhythms. Again, had 500 something patients. They looked at 30-day mortality, whereas COAT looked at 90-day mortality. Again, there was no difference between either of these things. So, what are the problems with both of these studies? The problem is that they excluded NSTEMI patients who were likely to benefit from emergent PCI. So, in NSTEMI patients who were thought of to be, at higher risk of actually having an acute occlusion, they were taken for emergent PCI, but they weren't actually followed up in these studies. So that leads to a certain selection bias. So recently, this was published in December of 2023 in Circulation, based by the American Heart Association. So about what exactly to do with these types of patients, especially out of hospital cardiac arrest. So they recommend a few things. One thing is what to look for in a history. So basically, the patient will come with cardiac arrest, you'll ask a few things about what exactly happened before the patient became unresponsive. So one thing is if the patient had chest discomfort or a history of myocardial infarction, if they had chest pain before the patient became unresponsive, or the patient had a history of myocardial infarction, that is associated with a 5-fold increased risk of acute coronary occlusion. Past history, you should look for things like coronary disease, previous MI, or any other CAD risk factors. One thing to note is that if the patient was having a history of limited mobility, history of dyspnea before arrest, and an initial rhythm of personal electrical activity, that is pointing more towards a diagnosis of an acute P rather than acute MI. if the patient is a youngish patient with a family history of cardiac arrest or a sudden death, then that would favor more of a genetic cause rather than an acute occlusion. But that again is changing these days because younger patients are now presenting with cardiac arrest. With acute MI, then it used to be maybe like 20, 30 years back. So what is the problem with post-ROSC ECGs? So this pains me to say, but post-ROSC ECGs are neither sensitive nor specific for acute coronary occlusions. And there is a high incidence of STEMI post-ROSC. And they have mentioned the incidence in this paper as well. So they're saying that around if you're doing an ECG within a few minutes of ROSC, the false positive STEMI rate is around 18%. Between 8 to 33 minutes, around 7%, and after 33 minutes, around almost 6%. So what they're recommend is that depending on how high your pretest probability of an acute occlusion was based on history, you may want to do serial ECGs and you may want to wait till the serial ECG after 30 minutes continues to show acute persistent duration before you actually push for the catheter. That is what they recommend. What about neurological assessment? It is not surprising that sometimes your cardiologist, they will, in certain centers anyway, they would prefer not going for emergent PCI until they are sure that the patient is likely to have good neurological outcome. But what is the problem with that? As we all know, the initial neurological examination after now hospital cardiac arrest is not going to be very reliable and should ideally be delayed after 72 hours. And they have mentioned clearly that it should not be the sole reason behind whether you decide to take the patient for emergent PCI or not. So neurological status, the M status, should not be the main reason behind whether you should go for emergent PCI. So what about focus? So again, these are some of the things that were not assessed in those studies as well. So if the patient is having RWMA on your focus, that will lead to a 3.75 increased risk of an acute coronary occlusion. So again, focus is something that you should be considering in these patients without estimation of these things. So they have given an algorithm. This is a big algorithm. I've only taken a part of the algorithm which is relevant for this talk. So basically, they have given this algorithm for acute management in the out of hospital cardiac patient after attending loss. So what you should do is, other than what we usually do to get an ECG alert, you will assess whether the patient is a palliative type of patient. So patient is very elderly, very bad comorbidities, end-stage cancer, etc. So if the patient is likely to be any kind of care is likely to be futile, then the patient is probably not a candidate for emergent PCI. So that is something that they mentioned here. So once you're ruled out something like that, then you look for these things. So one thing is escalation on the post-ROSC. That is a classical indication, as well as cardiogenic shock. So this becomes a little bit controversial because literally every patient with ROSC post after cardiac arrest is going to be having a shock of some degree or not. Electrical instability or hemodynamic instability, again, that becomes a little bit controversial. Then these patients will go to the cath lab. Even pulmonary embolism, they recommend to be taken for the cath lab for things like catheter-directed pulmonary thrombolysis. So basic things that you would look for is STEMI, cardiogenic shock, electrical instability. So recurrent VT, VF, etc. So these things they will require emergent PCI. So if the patient with cardiac arrest and stimulation of the ECG, so primary PCI is recommended over something like fibrinolytic therapy because it has been shown to improve the mortality rate. So this has been given a class 1 recommendation. So the problem here is that we have no recommendation for fibrinolysis during cardiac arrest, which is something that we do consider in certain patients because we know that patients with the cath lab is busy, you won't have the cath lab available, or you are working in a center without a cath lab anywhere near. So in those cases, sometimes we do consider for fibrinolysis during cardiac arrest or immediately after cardiac arrest, but they haven't given much guidelines about that, unfortunately. So what about shock? So shock, they have specifically mentioned cardiogenic shock. How do you actually assess for cardiogenic shock? You have to look at the history, focus, etc. Because obviously any patient after you achieve ROSC, most of them anyway, 95, 99% of the time, they will be having shock. So patient is having sepsis, they will be in shock. Pulmonary muscle will be in shock. So they most of the patients are post-ROSC, they will be in shock, and you'll have to determine if it's actually a cardiogenic shock. And if the cardiogenic shock is due to ACS, so it's not like patient is having DCMB, patient ended up in cardiac arrest. So those patients are not recommended to be taken for emergent PCI. So if it is thought that the patient is having ACS which led to cardiogenic shock, then emergent revascular restriction is recommended, and you are only going to do PCI of the culprit vessel, not anything else. So that is what they recommend. So it is a big article. I will share the link of the article as well. It's a very good read. But the basic funda here is that if out of hospital cardiac arrest you have attained ROSC and there is steady on the ECG, that they should be getting primary PCA as soon as possible. But the pitfall here is that you can have false positive STEMI in the immediate post-ROSC phase. So serial ECGs and and a good history as well. We'll look for the risk factor that we mentioned. These things will help you determine which patients will actually benefit most from emergent therapies. And and those cases without STEMI on ECG, you have to consider other factors. Look at the history, look at the focus, and also we are aware of things like OMI these days. So there are other STEMI equivalents on the ECG. Those are other things that you should also consider. And they have AHA is recommending an individualized approach to these patients. So there is no hard and fast guideline. You have to consider how each patient and the different factors in each patient before making a decision on emergent therapy. So that was all about this lecture, and if anybody has any doubt or want to contribute to the discussion, they can do so.